صباح الخير للجميع، ونعتذر عن التأخير لأنه شوي صارت ظروف طارئة. نرحب بالبروفيسور الدكتور إسماعيل، تفضل.
I would like to welcome Professor Khaled Ismail, MD, PhD, a professor of obstetrics and gynecology at Charles University in Czech Republic. He is the chair of the European Peers Group, member of the 4th European Academic Council, and consultant for the WHO Intrapartum Quality Care Program. He is going to talk to us about vaginal birth after C-section, where we are going. You are welcome, Jerusalem. Thank you for coming, and please go ahead. The mic is all yours.
Thank you very much for this very kind introduction. Good morning, everybody. Thank you very much for the Society for their kind invitation for the second time. And special thanks, of course, to Dr. Nihad and Dr. Sufyan for their invitation as well. So the topic I'm going to talk about today is planning VBAC or TOLAC or whatever terminology you want to say. I think we know what we are talking about. So this is a world map showing the variation in Caesarean section rates throughout the world. And this map is in one of the WHO reports. And apart from the variation you can see that the Middle East region also has a lot of variation. However, it seems, according to this map, that Palestine does not have a very high Caesarean section rate, certainly not as high as Egypt. However, it's important to highlight two things. One of them is that, according to the title of this map, these are global estimates. And if you look at the bottom of this map at the date, the data is almost 10 years old. I can share with you some of my personal experience because I have been tasked last year. I've been tasked last year and this year to deliver some hands-on training workshops in Palestine. I've been tasked by the WHO in collaboration with the Palestinian Ministry of Health. And I've been fortunate enough to do this training in quite a few locations in Palestine, as you can see. Actually, last week, I just came back from Gaza. I was in Ramallah yesterday, and I'm going back again to Ramallah. We have trained about 150 doctors and midwives. And one of the things that keep coming up in the discussion is the increasing Caesarean section rate. So healthcare professionals feel it is going up. And interestingly, a lot of them actually probably know why it is going up. But just looking at a crude figure of a percentage does not really give you so much information. As you all know, it's not new information. What we try to do is to relate the Caesarean section rate to the Robson groups that we know about. And Robson classification, of course, is adopted worldwide, adopted by the WHO. It's a very simple, but also very smart classification because it divides our cohort of women that we look after in labor into different categories. However, I want to focus today, obviously, on group 5. These are the women who have a scar in their uterus, and they're coming back for a delivery. So this is the group that we are going to maybe attempt and try to do a VBAC for. But I also want to highlight two other groups. Group 1, these are the nulliparous women who are term, singleton, cephalic, and they are in spontaneous labor. And group 2, these are nullips again, and they're term, singleton, cephalic, and either they are delivered pre-labor, i.e. elective Caesarean section, or are induced and either end up with a vaginal birth or a Caesarean section in the context of what I'm talking about today. So these three groups are groups I would like to focus on. I want to share with you data that has been around for a while. This is an important study, although it's only a retrospective analysis, but it is important because it gives us a global perspective about what's happening to Caesarean section rates. And in this retrospective analysis, they used 2 WHO global surveys that were involving more than 21 countries and more than 280 healthcare facilities. And then they compared 2 time periods. One of them was between 2004 and 2008, and the other one between 2010 and 2011. And the crude information, the observation, is that the cesarean section rate has gone up in the second phase compared to the first phase. So it has gone up from 26.5% almost to just over 31%. And this difference was significant. Of course, it will be because you have a huge number of individuals involved. But when we look at this data in a different way, again, according to Robson groups, you will find that the first 5 Robson groups are the biggest contributors to cesarean sections all over the world. But again, particularly group 1, 2, and 5. And these 3 graphs are divided by whether these countries are high, middle, or low income countries. But you can see that the pattern is almost the same, whether it's a high, mid, or low income country. The biggest contributors are groups 1, 2, and 5. These bar charts have a solid bar and have a shaded bar. The solid bar is the first survey, and the shaded bar is the second survey. And you can see that in group 1 and group 2, the shaded bar is going up. So it seems the rates are going up in group 1 and group 2, whether you are in a high, mid, or low income country. However, group 5 is slightly different. Group 5, in the high income countries, the rate of cesarean section seems to have dropped a little bit. However, the rate of cesarean section in mid and low income countries still actually continues to go up in that cohort. Why is this happening? Why group 1 and 2 seems to be going up rather than coming down? First of all, before we talk about group 5, maybe because parity is reducing. So the proportion of primary parous women compared to the total number of deliveries maybe also is reflected in that. Maybe we are worried about medical legal problems. That's why we have a lower threshold to do cesarean section. Maybe women are having their first baby a little bit older than before, and that's why the cesarean section is going up. Or indeed, with regards to group 5, maybe it's a dominoes effect. When you push one domino, the rest of the line falls down. And of course, if 1 and 2 go up in a few years' time, group 5 will go up because these women are going to come back and have a cesarean section. I'm highlighting here that although group 5 has come down in high-income countries, it's still, indeed, the biggest contributor to cesarean section rate. And it is for this reason that VBAC became really and continues to be quite topical. Why are these cesarean section rates going up? Again, we can reflect on this a lot. In Europe, people blame a lot maternal request, maybe the same thing in the Middle East. We've heard yesterday that the cesarean section rate in Egypt is really high, and I can confirm this for you because this is where I come from. And certainly rates are going up, both in the private sector. People always blame obstetricians. They don't want to wake up in the middle of the night, or they want more money. But the fact it's going up in the government hospitals, and this is obviously everything there is free. So the problem is not only maternal request. So let's just revise a couple of slides about VBAC. VBAC as a universal statement agreed upon by NICE, by the RCUG, by ACOG, by every organization that produces guideline. People consider it clinically safe for the majority of women. Of course, we can't say 100%, as long as these women have only had one previous lower segment cesarean section. And of course, it has huge health economic benefit if we can actually achieve VBAC successfully. However, there are some contraindications. We are all aware of this. It's something we studied as undergraduates, and over the years, it has not really changed very much. And so this is information that has been there. There are also risk factors that would increase the woman's risk when they go for VBAC. One of them is a bit controversial, like a short interval between deliveries. But of course, the other factors, and we've heard a lot about obesity yesterday and today, and of course, it's a global problem, it's a global pandemic, is something that certainly increases the risk for the woman. There are lots of complications. Actually, the complications, apart from the uterine rupture, they're not as high as we think. So if you look at the rates of perinatal death or hypoxic ischemic encephalopathy or maternal mortality, they are there, but these rates, the risk is really fairly low. The biggest problem we all think about when we counsel or think about VBAC is uterine rupture. And this risk is about 0.5%. So when we counsel women about this information, of course, when we counsel women, we have to achieve three things. We have to be informative, we have to be non-directive, and we have to be non-judgmental as much as possible. We also try to individualize the information to women so that the woman herself can make the choice that she thinks is the right choice for her. And when we counsel women, this is what the guideline tells us we should really discuss. We should discuss that the risk of ruptured uterus maybe is different if the woman is starting a spontaneous labor compared to if she's induced or augmented. We should talk about high success rate. The success rate is even higher if somebody is coming for their second VBAC. We also mentioned that maybe there is a slight increase in the risk of obstetric anal sphincter injuries, and there is a slight increase in the risk of operative vaginal delivery. But the question is this information enough or not? Certainly, when it comes to uterine rupture, it's a situation that none of us want to be in that situation, especially if the woman ends up losing her baby and sometimes losing her uterus. So one of the things that is certainly in most of the guidelines, and it has been in the RCUG guideline for a long time, is actually measuring the lower segment thickness. And it's something that people don't routinely do if they counsel women about VBAC. Although, if you see from this meta-analysis, it has really a very good negative predictive value if the lower segment thickness is between 2.1 and 4 millimeters. And this can be done either transabdominally, so it's fairly accessible for most of us. And if this is, and if you are good with transvaginal scan, it can also be done transvaginally. But I want to discuss a few other things as well. What about toe lac and levator avulsion? Levator avulsion is becoming more and more topical. It's a trauma that happens, it's hidden, we can't see it, but we see its consequences much later on in life. And this is a study from our group where we looked at the risk of levator avulsion in women who undergo VBAC compared to controls. These are primogravids having their first birth. And actually the risk of levator avulsion in this cohort of women having a toe lac is higher. It's actually doubled. So a primogravid has a risk of about 1 in 6. For women having a VBAC, they have a risk of about 1 in 3. And these can either be unilateral or bilateral levator avulsions. Of course, levator avulsion plays a key role in pelvic organ prolapse. It quadruples the risk of the woman developing a POP in her lifespan. Also, it increases the risk of recurrence after POP surgery. What about toe lac and oasis? The guideline says maybe there is an increased risk. Again, this is another study from our group where we looked at a cohort of women undergoing VBAC, and there is indeed an increase in the risk of obstetric anal sphincter injuries. Of course, these units that have participated, where I work, in Pilsen and in Prague and the Czech Republic, they all practice interventions to reduce the risk of oasis. So despite manual perineal support and cutting only an episiotomy when needed and cutting it at the correct angle, not the right angle, at the correct angle, still actually the risk is there. And this risk is there, although there is no significant difference between the two groups with regards to birth weight or operative vaginal delivery. And these are the two biggest confounders for the risk of oasis. So it is a reality. Another issue is the risk of perineal tears in general, not only oasis. And indeed, women undergoing VBAC, just simply because of the virtue of the fact that this is their first vaginal delivery, so their uterus is a uterus of a woman who's a multiple in a way, but the perineum and the vagina are those of somebody who's a prime. And of course, babies also go up a little bit. That's why the risk probably increase slightly. Also, the risk of cervical lacerations in our study was a little bit higher, but in the Czech Republic, they have this system of routine examination for the cervix, certainly something we did not do in the UK. We also practiced in Egypt. So I don't know what happens in Palestine. My opinion is if somebody's not bleeding, stop messing about with things. What about TOLAC and type of previous cesarean section? And this is really something important we have to take into account when we counsel women. So what type of cesarean section has happened before? We've heard yesterday from Professor Daly that women having a cesarean section at full dilatation have a higher risk of preterm birth because you're cutting through the cervix. We all know the uterus starts pulling up, and if you do the cesarean section very, very late, you're more or less opening the cervix. But also if you do the cesarean section very early, as in elective cesarean section, your incision is much higher up. In this first study, again, this is a study from that I mentioned before, but this is one of the outcomes we looked at, was how long does it take women to deliver a VBAC when we compare the duration to the type of previous cesarean section. And as you would expect, women who have a cesarean section as an elective procedure or very early on in labor, when they go for a VBAC, it takes them much longer to deliver compared to women who have had an emergency cesarean section. And this data I'm going to share with you are data provided to me by my friend and colleague, Professor Rasha Kamer from Cairo University. And this is a study done jointly between Cairo University and St. George's in London. And they looked at the type of scar compared to whether the cesarean section was elective or emergency cesarean section. And they have noticed that elective cesarean sections were associated with a higher risk of niche formation. And niche is known to be positively correlated with the risk of morbidly adhesive placenta. So maybe we should really think about that when we counsel women, when we assess scars even before they get pregnant so that they know what they're getting themselves into. But also we need to think about it when we do our first cesarean section. So to conclude, VBAC is not a one-size-fits-all. You have to individualize your care, both in counseling and in management. Screening and counseling for VBAC should start before the pregnancy, in my opinion, and should be, again, reviewed throughout. Of course, women's informed choice have to be based on evidence, which we provide in the form of information, and we should use objective measures. And by the way, Robson Group 1, 2, and 5 with regards to cesarean section are called core maternity outcomes. These are outcomes that really make a difference when we compare practices in different units and between different countries. And if we want to introduce new quality improvement projects to really reduce cesarean section rate. However, although I'm talking about VBAC, I want to highlight that the only way for us to reduce cesarean section rate in the long term is to address group 1 and group 2. Because these are going to fall down and create this dominoes effect and increase group 5. And please give particular attention to group 2, which are the elective or early labor cesarean sections. They seem to have the worst scars that increase the risk of placenta accreta. They also seem to prolong VBAC if this woman changes her mind or moves to another country where they adopt a VBAC policy. So at least give women a true chance before you do this. And part of our training really for the WHO was to facilitate implementation of the new partogram, the labor care guide. And it's very interesting if you look at it with regards to how you manage labor with regards to its duration. And I would like to thank you very much for your
شكرا دكتور خالد على هذه المحاضرة القيمة. إن شاء الله كل سنة نشوفك بمؤتمرات.